Hello, and welcome to our review of the lupus literature from January. We record these podcasts for you every month, so you'll be able to keep up to date on the latest literature and expert opinions. I'm Professor Viveka Strand, Adjunct Clinical Professor in the Division of Immunology and Rheumatology at Stanford University School of Medicine in Palo Alto, California, and a biopharmaceutical consultant. Today, I'm joined by Professor Eric Morand, who is Dean of Clinical and Molecular Medicine at Monash University in Melbourne, Australia. Welcome, Eric.
Hi, Vibeke. It's great to see you and pleasure to take part in this podcast with you.
Well, I'm going to let you take it off.
Okay, well, the first paper that we're going to cover today, I have to declare a conflict of interest. I'm one of the authors of this paper, and it's entitled Association of the Lupus Low Disease Activity State and Remission with Reduced Organ Damage in Flare in SLE patients with high disease activity. Bit of a mouthful, but there's a reason that we did this study. So what is high disease activity? There are several definitions floating around, but the most widely used definition of high disease activity in SLE is people with a disease activity greater or than or equal to 10 as measured with the SLEDAI-2K. The SLEDAI-2K is a scale that assigns points at different weights for different organ manifestations. And to have a SLEDAI of 10 or more, you have to have at least one major organ affected, such as CNS or vasculitis, or multiple other organs affected, such as renal, cardiac, serological, skin, hematological, etc. And either of those cases represents a patient who's in trouble. We and others previously published papers looking at the outcome of people with high disease activity. And if you ever have an episode of a SLEDAI of 10 or more, then you are at higher risk for adverse outcomes, including higher risk of damage accrual, greater corticosteroid exposure over time, more flares, etc. So it kind of is a marker of patients who are at high risk and potentially in need of intervention. Interestingly, it's also equivalent to the average disease activity of patients enrolled in clinical trials. Patients enrolled in clinical trials in the last few years have been enrolled requiring a SLEDAI greater than 6, for example, but the mean SLEDAI in most trials is 10 or 11. So everything we know about recently trialed therapies in lupus, such as belimumab, anifrolumab, and the other drugs that have been in phase 2 trials, is based around cohorts that look like this, have a mean SLEDAI of around 10. So often low disease activity and remission attainment are measured in these trials. What does it mean to attain low disease activity or remission at the end of 1 year if you start with a SLEDAI of more than 10? So those are some of the reasons that we wanted to do this study. Of course, low disease activity and remission are concentrically more stringent states of treat to target achievement, each of which has been developed and prospectively validated in the last few years and now appears in the most recent treatment guidelines as the goal of care. The primary goal of care, of course, is remission, but this is attained infrequently in patients with active disease, and low disease activity has been shown to be a very protective alternative state for people who can't get into remission. So we did this study using data from the Asia-Pacific Lupus Collaboration. This is a prospective, multi-center, multinational cohort study that's been running in the Asia-Pacific region since 2013. In this case, we used a data cut from 2013 to 2020, which was a baseline of around 4,000 patients with SLE. The first result of this paper was that we looked for people who had had at least one episode of high disease activity, and 27% of patients had at least one episode of a SLEDAI of more than 10, of 10 or more, I should say. That's a slightly disturbing statistic that more than a quarter of patients had this. These are patients managed in excellent centers around the region, and to have so many patients having such a high state of disease activity alerts us to the fact that standard of care needs to be improved. So that represented just over 1,000 patients who were followed over time. Their visits were synchronized to that episode of high disease activity, and then they were followed for a mean of 2.7 years after that, measuring things like their disease activity over time, flares, damage accrual, and so on. So the first result is, did these patients succeed in achieving low disease activity or remission? And pleasingly, they did. 70% of patients followed for a mean of 2.7 years achieved low disease activity at least once, and 40% of patients achieved remission at least once. However, attaining these states just once, touching down, as it were, on these states, is not as protective as attaining them for a longer time. Only 21% of patients with high disease activity achieved low disease activity for more than 50% of their follow-up time, and only 37% achieved at least 3 months of sustained low disease activity. In the case of remission, 21% achieved remission for 50% of the following time, and 28% achieved at least one episode of sustained remission. So we can see that rates of attainment, of sustained attainment of these target states for people who start with high disease activity is unacceptably low. Now, what happened to those people who did attain these states? One of the questions that's arisen from these descriptions of treat to target states validated in cohort studies is, if you're measuring people in low disease activity or remission and showing that they do better, is that just patients who are always in low disease activity and remission? In other words, patients with mild disease. We need to test whether people who start out bad but manage to attain these states, in fact, exhibit protection. And that's really the major finding of this study, which shows that people who started with high disease activity, who ever attained low disease activity, actually had a 50% reduction in the risk of damage accrual. People who attained low disease activity for 50% of time had a 50% reduction in damage accrual. And people who had at least 1 year of sustained low disease activity had a 78% reduction in damage accrual. And the numbers for remission were similar, slightly better, in fact. Reductions in damage accrual and flare were similarly seen. So in summary, this retrospective analysis of prospectively collected data showed that the rate of high disease activity episodes is high, that attainment of low disease activity and remission in these patients does not happen as often as it does in other patients, but can be attained. And when it is attained, and especially when it is sustained, such patients are indeed protected from long-term adverse outcomes of their lupus.
Well, thank you, Eric. I think one of the points of the paper is that you see that DORIS remission is not that easy to attain. And LLDAS has become a very valuable outcome. It's a clinically meaningful outcome, and it really is a way to say that patients are doing better and going to continue to do better and avoid damage. So, as important as this data is, it's another point of how important LLDAS is. So
Yeah,
we
you're right. I
appreciate
mean,
APLAR for having developed it.
well, when we started that work on low disease activity, papers had shown that remission was very rarely attained, and we needed a treat to target state that was valuable to the patient, but attainable. Otherwise, we would be just talking about ambition and aspiration.
Exactly.
There's a chance with better and better therapies and earlier diagnosis and intervention that we will have more patients in remission. And it's great to know that when we do that, the protective effects are very good. But I agree with you. In the meantime, we know that attainment of low disease activity is meaningful.
Yeah. And you pointed out also early diagnosis is really important. And there still is considerable amount of delay in that occurring. Not just because there aren't enough rheumatologists.
No, that's true. We have this terrible conflict between delayed diagnosis of people who've got lupus and over referral of people with a positive ANA and otherwise well. And at least our systems struggle to differentiate those people at the point of care where they're being sent to us for us to work out which ones we need to see sooner. And it may be that some advances in biomarkers, for example, may help us to separate those patients and prioritize care, but I don't think we're quite there yet.
I think it's a very important point. Well, the other paper we were going to review today was the 2024 APLAR consensus on the management of lupus nephritis. And this is by C.C. Mock et al. And it's really the results of a Delphi process, a two-step Delphi process from members of the APLAR Lupus Special Interest Group. And what's interesting about these guidelines is they're not too different from what was just released at the ACR meeting in November. And as well, they're not too different from the EULAR guidelines for a couple of years ago, but there are some minor differences. But the point is really that these are important in terms of the type of lupus patients that are being treated and how is their tolerability to various therapies. So these were largely based on the APLAR recommendations from 2021 for lupus. And then the core members formed a special interest group and did a literature review, which was available on PubMed. And 56 statements were drafted and selected by the core group based on the search results and the clinical practice evidence graded A to D. And they then did the Delphi, which was anonymous voting and feedback were done through online platform, very similar to what OMERACT does. 46 doctors, 21 Asia Pacific regions who have considerable expertise in managing lupus nephritis, and 2 lupus nephritis patients who were actively involved in self-help group activities. And from that, 48 statements were agreed upon. The consensus level was greater than 80% for all the statements, and the mean agreement was a score of greater than or equal to 7.5 out of 10. Now, the overarching principles are what we generally agree with. Obviously, that optimal management of lupus nephritis requires an early diagnosis, decision-making process in terms of how to treat patients, which is shared between patients, physicians, and also thinking about the resources across the APLAR regions and knowing that availability of therapies may differ, that physicians should monitor their lupus patients for renal involvement and refer them promptly to a specialist for the proper management, and that they should continue to monitor lupus nephritis very carefully and closely. And this is a long-term goal of all of us, and trying to prevent renal and extrarenal flares and minimizing treatment failures, etc. Also, of course, there's an induction phase for treatment of lupus nephritis and with more intense immunosuppression, and then a maintenance phase, and the therapies may change between the two. And what we see about the APLAR recommendations that are a little different from the ACR and maybe the EULAR is that the current ACR guidelines are now saying triple therapy at all times. And this is not true for the APLAR guidelines, although it is included as an option. And this may also have something to do with mycophenolate mofetil not being as well tolerated sometimes in Asian patients. And there are also being differences in doses. And so the choices of the therapies have to do with people's familiarity. And calcineurin inhibitors are much more broadly used in Asia, for instance, than they've been used in the United States. And when we talk about CNIs, most think of the voclosporin, but there are several others. And there's certainly a very much reason to think of all of them as being effective therapies. So in general, these are very interesting guidelines, overall consistent with how we think about treating lupus nephritis. And it's a nice pragmatic approach to the management of lupus nephritis in the Asian Pacific subgroup of patients. And I wonder, Eric, if you have any comments?
Yeah, thanks, Vibeke. I've got comments and a couple of questions as well. So I think importantly, this is a guideline for care of lupus nephritis in the Asia Pacific region. So it focuses on access to investigations and treatments in that region, many countries of which are much poorer than the countries that you and I live in. For example, some of the patients in our cohort study don't have serology measured on a regular basis because the patient simply can't afford even that relatively simple thing. And so the attempt to be pragmatic is about patients in the region, which refers to, I guess, the individuals, the patients themselves and their ancestry, but also the region. I don't think this should be interpreted as a guideline for the care of patients of Asian ancestry living somewhere else. It wasn't
Yeah.
designed or intended to say, if you're in California and you're treating someone whose ancestors are Chinese, you need to change the way you manage them. I do think that applies, as you correctly pointed out, to things like mycophenolate dosing and so on. But I just wanted to call that out. Of course, the Asian regions made great contributions to the nephritis space. The best studies of tacrolimus probably come from the Asia-Pacific region, and one of the original high-quality studies of mycophenolate, of course, led by T.M. Chan from Hong Kong as well. So the contributions have been very meaningful from this region. Vibeke, I wanted to ask your thoughts on the, I guess, softer recommendation for multi-target therapy in these guidelines. And do you think that that is chiefly, a biomedical position, or do you think it's more reflective of resource and access?
That's a good question. I think
Mhm.
it's more resources and access, but I do think there is something to be said for basically genealogy and ethnicity and so on, which we know in the United States makes a huge difference among all of our different lupus patients. And so I have to think that that's also applicable to the Asian Pacific populations where there's a fair amount of heterogeneity too. And
Mhm.
we know there's differences among the Asian lupus populations.
Mhm. Yeah. I think one of the important things about this guideline as well was aligning the recommendations for lower glucocorticoid dosing. Historically, patients in the Asian region were exposed to higher average glucocorticoid doses than in other parts of the world, partly reflecting access to other therapies, but also partly reflecting the training and so on. And in some places, antimalarials were not routinely used in people with lupus nephritis. So I think modernizing those two aspects and aligning them, I think it sends an important message to people taking care of these patients through that region that everyone should be on antimalarials and basically, as Fred Husso said, think of a steroid dose you want to give and halve it.
Yeah, I think it's a very important point. Actually, now all the guidelines, EULAR as well as ACR as well as Asian Pacific, are saying that you try to go for a goal of less than or equal to 5 milligrams of prednisone daily or prednisolone equivalent. And that's a very important guideline, which is relatively new.
Yeah. Now, Vibeke, I'll try to draw you out on something now that neither of us have seen published, but we've all seen a press release that the obinutuzumab CD20 monoclonal antibody had a positive lupus nephritis trial. We haven't seen the numbers yet,
Yeah.
but do you think, I mean, it's great to have new options coming towards us, but I, I wonder whether we're going to be having rather frequent updates of our guidelines as these new medicines come to us, which we're not used to in lupus. Is that what you think is going to happen?
Well, I actually hope so.
Yeah.
You know, plus we have CAR Ts now, and we have BiSes and TICEs and all sorts of other cell-based therapies that are approaching.
Hmm.
And I think there's also the possibility of being able to do these in a more cost-effective manner and make them more available through
Hmm.
allogeneic and pluripotent stem cell preparations.
Yeah.
So I expect that things are going to be changing fairly quickly.
Yeah. Yeah. Let's look forward to that.
Yeah, I hope so. So I believe we are done. I'm sure that we've actually said a little bit more than we should have, but it was a great discussion. I really appreciate that. And so what I wanted to say to you is that please listen, find the slide decks for these papers in lupusforum.com. It's free to access, and all our content is free to download. Don't forget to register for updates on the Lupus Forum. You'll receive email updates when new content is made available. You can follow us on Lupus Forum, all one word, on Twitter and LinkedIn. Thanks again, and see you next time.